Good evening, everyone, and welcome to the League of Women Voters of Berkeley, Albany, Emeryville's fall meeting. We're happy to have a great panel for you this evening, and the focus is going to be on health equity, reproductive justice. So we'll be touching on a variety of really important topics. And Sharon will be leading us this evening along with our guests. So I'll turn it over to you at this time, Sharon.
Thank you so much, Candia. We're very lucky tonight, and I think some of you have been seeing the changes of what has happened, but we were expecting the head of Planned Parenthood to come, and there was a family emergency, and I was very lucky to find two illustrious speakers who are going to take us down this topic as well as anyone else we could have found for this, and really appreciate we nurses are very good at being flexible and jumping in at the last minute. So I'm going to start by introducing Kathleen Dowd, and then she will introduce Olivia Favela Gary. But Kathleen Dowd is someone I've actually been following on social media for a while, so it's really fun that she's here. She is both a nurse practitioner and a midwife. So she has her master's in nursing. She is the president of the California Nurse Midwives Association, and she was president when the organization helped pass legislation that removed physician supervision, which really opened up the full scope of practice for midwives. And, midwives are a great way to have a baby. That's how I've had my children. She is also the founder and co-chair of the California Nurse Midwives Foundation. And so, of course, when we do this, we're looking for some financial resources, both for the League of Women Voters, but also for the California Nurse Midwives Foundation. And I'll get a link in the chat. So thank you again, Kathleen, for jumping in. And we're so excited to have you both.
Thank you. So I'm not sure how many people are here, but thank you for being here. And please know that this is very last minute, like as of today. And I just drove home from Lake Tahoe, so I've been home for an hour. Didn't prepare anything, but to go back, I've been a nurse midwife for about 30 years. Over the course of that, over the course of my career, midwives were sort of within healthcare systems, but really had very, very little power and were not involved. We tried to be involved in advocacy and policy, but it's a very hierarchical system in the institutional healthcare system. And so midwives often did not have much of a voice. But midwives make a huge difference in people's birth experience. We are really experts in normal birth, and in saying that, we are really taught to educate and listen and support and give people the time they need and be there where they are in their process. Whereas physicians are really educated to take care of emergencies, do surgeries, things like that. It's not that they can't do normal, but they're really not trained to do that. And so I'm going off on a tangent, but I'm going to keep going. In many other countries, midwives are the mainstay of reproductive and maternal health care. And they have much, much better outcomes than we do. I don't know if any of you know, but we have the worst outcomes of any industrialized nation when you come to maternal and neonatal outcomes. And that is really a sad statement. So over the course of my career, I got involved in advocacy. I was tired of just making a huge difference at the bedside, and I wanted to make a difference on a larger scale. And so I became the secretary and then the president of our professional association. And in that process, we attempted to change legislation. Over 5 years, we had 4 different bills, and the last bill finally did pass. We had to go up against California Medical Association, was probably the biggest lobbying group, most powerful lobbying group in California. And historically, our lobbyists had done that work. And the last time, Holly Smith, who's also into health policy and advocacy, and I negotiated the language and negotiated with them and basically said, we're not going to back down. So you can keep doing this with us year after year, but we are not backing down. And it finally, really the legislature realized that, there was a need, and their arguments really didn't hold. So our legislation went through. We removed physician supervision, which really opened up practice for us to take care of women independently. It doesn't really make a huge difference necessarily in the hospital realm, in many hospital systems, because there's still medical staff and bylaws and all that stuff. And that passing legislation is step number one. There's so much more advocacy that has to happen. In the process of passing legislation, I realized that that was step number one, and there was so much other work to be done, and there's no money in reproductive and maternal health, or very, very little. So I started a foundation to try to raise money to address inequities and injustice. It was 3 midwives at first. We were very small. We've grown exponentially. We've now raised over $1 million. We try as hard as we can to get that money out. And our 3 main things we do is advocacy. We support student midwives of color, and we support midwifery projects of midwives of color and in communities of color. This is where we need to do the work and make the change. If we improve outcomes for that population, we improve outcomes for everyone. As part of the foundation, Olivia came on as a member at large, and then a co-chair with me. And then when we grew and we were going to hire an executive director, she made it clear that she really wanted that role. So she's now the executive director of the foundation. So I'm going to go ahead and introduce her now. She is a certified nurse midwife. A lot of us are also nurse practitioners in women's health. She has her master's degree, and then she went on to get her doctoral degree. I'm not sure exactly what exactly that's in, but Olivia will speak to that. She's a practicing midwife, and as I said, the executive director of the California Nurse Midwives Foundation. She's also the mother of 3, and she's very involved with advocacy and policy in the reproductive and maternal health care space through the foundation and in other ways. And she's been a leader in midwifery in the Southern California area. So I hand it off to her.
Thank you, Kathleen. Hi, everybody. I'm Olivia Favela-Gary, and as Kathleen already said, I have been a nurse midwife now for 11 years in Southern California. I actually studied and did my integration there in the East Bay at, I'm going blank all of a sudden, at the hospital that I love, and I can't remember the name now, at Highland Hospital, actually. Yeah, at Highland, which I love, love, love. So I spent a lot of time up there in Berkeley and Oakland in the East Bay. Yes, my journey here, I would say it's interesting, but not that interesting. When I was in nursing school a long, long time ago, when I grew up thinking I wanted to be a doctor my whole life, I was like, I want to be a healer, I want to be a doctor, because that's the only modality I had ever heard of in this country, right? Born and raised here. Then I was undergrad and I said, I don't think I want to be a doctor. I don't think I'm going to get to really be with people. And so after I graduated, I took a year off and I was wandering and somehow found nursing. I started volunteering in hospitals, and I noticed that the nurses were the ones who were really providing this patient care. And I said, maybe I want to be a nurse. I had never thought about it. I had never even heard of it as a career. And the next fall, I went into nursing school. When I was in nursing school, though, I always said I wanted to deliver babies. And I'll never forget this. One of my professors, I was saying, I think I want to be a midwife. And they said to me, you don't want to be a midwife. Midwifery is dead. That's not a real profession. You should become a nurse practitioner and do like family nursing. And so then I thought, okay, I'll somehow figure out a way to maybe go to another country and be a midwife and deliver babies, and then I'll do all these other things. Then I kid you not, I read the book called Call the Midwife, which later became a TV show, and this was before then. And I just read the story about the way women in other countries, this was specifically in England, were caring for the people of their community. And I said, I knew I wanted to be a midwife. I know there was a way to do this. And lo and behold, within the nursing umbrella, and we could talk about this forever, how midwifery is under the nursing umbrella in the United States and how it got there. But that is where it is now. And so I went and I got my master's to be a nurse midwife, and I got my doctoral degree in nursing practice. So the highest degree in nursing, because I wanted to focus on education and policy making and still practicing and changing clinical practice. So my work in these last few years has really focused on advocacy work, on kind of just bringing attention to the ways that the system maybe thinks it's working, but really isn't, right? And I think a lot of us, when we get into this work, especially when you talk about reproductive justice, which isn't really just a health framework, it's a justice framework, a racial framework. It really is a framework that is talking about centering people in the community. Where is the power, right? When you're talking about health, when you're talking about resources, when you're talking about reproductive rights, well, if you have no choices, do you really have rights? Right? Can you really make decisions? And so when I think about reproductive justice, I think that's what brought me into midwifery. It's like, how do you bring a voice to the people who maybe are overlooked? If the laws leave you out, if the system leaves you out, then do you really have choices? Right? So that's kind of where I started and really looking around and then getting into midwifery and realizing it wasn't that common, but people who look like me were not very represented, right? I'm Black and Mexican. I think in the state of California, we have the largest number of certified nurse midwives in the country. I think they're like 1,000 of us or 1,500, I'm not sure. We are like 1% Black and Latinas even less. If you talk about, there's another type of midwife in the United States who's recognized. They're called licensed midwives or certified professional midwives. And there's more diversity there. And there is a long history as to why that is. And we can get into it later if anybody has a question about that. But realizing that I was in a space that we weren't really recognized, but somehow we are still talking about women, and women are also still second-class citizens. Midwifery really, to me, is the answer for everything. When people want to know how can you get involved in women's rights and reproductive rights, in giving a voice to the voices, midwifery is all of that because it is about all of us. Anybody who is of reproductive age, who has ovaries or uterus or breasts, it is for you. That is who we are here for. And so that is me. So I'm so lovely to be here. I'm so happy to be here.
I can piggyback on a few things that Olivia said. One of the things I said is midwives take care of normal, but actually nurse midwives, which we are, work mainly in the hospital, and we collaborate with physicians, even with high risk and moderate risk women, so that they can receive the type of care, kind of comprehensive, gentle care that midwives give, basically. When Olivia was speaking to, I don't know if this is supposed to be a talk all about midwives, but it is the answer. When Olivia was talking about, she is not the typical, when she came into midwifery, individual who would choose this profession. We are a profession of 90% white women. And we take care of a lot of communities of color because we work in a lot of health clinics that are state and federally funded. And that has to change. And that's why Black women in our country die 3 to 4 times, Black and Indigenous women, 3 to 4 times more than white women in our country. And I think one of the huge answers to that is to bring more people of color into the maternal and reproductive health space so that they can advocate for their people, but it's not their job. It's also so important that we bring them, encourage them to become leaders in our communities, our healthcare communities. And when you look back over history, midwifery was where all babies were delivered in this country, and it started back with Indigenous women and slaves. The Indigenous women and the slaves delivered their own babies within their communities. And then when the medical establishment took over birth and reproductive care, those midwives were ostracized and considered dirty and out of the hospital and things like that. And so midwifery became something that went away. Basically, they tried to erase it, and then it slowly has come back over time. And we haven't always done it right. That's why there are so many, we are so disproportionately white, but we are working very hard at the foundation and the association as well to change that.
So such great points. And I just both could maybe take a deeper dive into, you were saying like our birth outcomes for the developed world are so poor compared to other places, and they're especially bad for, birthing people of color. And I was wondering if you can think of like what is in the structure that actually sets this up that may be able to be addressed by policy.
Just really quickly, Sharon, I wanted to address that there was a question in the Q&A.
Yes, great.
So the question is, on the Mendocino coast, mothers have to drive over an hour to give birth since the hospital's OB department closed. How do we train in rural areas so mothers have a choice to have a midwife? Kathleen, do you want to answer that or do you want me?
Why don't you dive into that with what we're doing right now as well, with trying to open or remove the restrictions for birth centers to open in spaces where hospitals are closing. There's a crisis of maternity units closing in hospitals because they don't make money, they lose money for hospitals. But is that the value of what women do? Is the fact that how much money people can generate on our bodies? I mean, anyway.
Yeah, I mean, I would say I agree with you. Here's the problem. The crux of the issue is that we have a for-profit healthcare system, right? So when you have birth in hospitals, it's almost like an emergency room. Unless you can keep volume high, we are always in danger of losing the labor and delivery unit, right? The hospital's always like, what's the point of having them? You have staffing issues, they don't really bring enough money. So then they close. Luckily, in a lot of rural areas, you do actually have quite a strong spirit of community midwifery. That's where you would have a lot of licensed, and also some CNMs do out of hospital birth. So the first would be to familiarize yourself with the community midwives in your area. Okay, because a lot of community midwives, those who offer home birth or or birth center birth, so out of hospital birth, will drive a considerable distance. They'll either come to you. So that's the first. Familiarize yourself. You can do it with a Google search. You can go to any of the professional sites because they have like Find a Midwife. So you can go to ACNM site. You can go to CALM, which is California Licensed Midwives. So you can look that up. So that's the first step. I would say familiarize yourself with what's in your area. Secondly, when it comes to training midwives, when you're looking, that's more of a systemic issue. It's how do we get more access to midwifery education? What kinds of midwives? You're talking about licensing. It can be very, very overwhelming. So one of the things that we do at California Nurse Midwives Foundation, the ones that we work is we work on the student level. How do we bring down the barriers for people to get into midwifery? Right? A lot of the time it's money. Can you go to school? Can you get a postgraduate education to do that? Do you have the time when you have to go to your clinical rotations and you've got kids and a partner? Can you do without the extra income, right? So how do we address that? So we work on getting scholarships and really supporting adults, especially people of color, people LGBTQ plus communities to go back to school, right? The support that you actually need to do that. Then are there programs available, right? What kind of pathway do you want to go to? Then, once you are a midwife, like you said, if you want to serve the communities that are underserved, specifically in these maternity care deserts, that's what it's called when you don't really have anything within 10, 15, 20 minutes. How do you serve that? Well, you have all of this legislation and things that make it very difficult for women to or midwives to start birth centers. And birth centers are a really great option because people can leave their house and go somewhere. So you have access, they have really great outcomes, but they're not very sustainable for a lot of midwives. It's a tough business model. A lot of the time, you can't get covered under insurance, so insurance doesn't reimburse you, right? So there are a lot of things. So our organization also helps because we support policies that try to bring down those barriers, right? So we support that we're trying to increase access for you to get midwives and get midwifery care. So as far as training goes, the root of your question, how do we train in rural areas? It's usually that it's seeing how we can support people to go back to school and do this because I'm sure you guys have heard of doulas, right? So doulas are labor support people, but they're not trained, they're not trained professionals, they're not trained medical professionals, they don't deliver babies, right? But to become a doula, you have much more access to that. It can be a weekend course, it can be something simple like that. To be a midwife, it is actually a profession. So you've got to go to school. It is quite arduous and it is quite challenging. So it's hard, but the trick is to support those who do want to get into it. Scholarships, starting new programs. We are also working on closing the gap between nurse midwives and licensed midwives. So remember, Kathleen and I are certified nurse midwives, which means that we're registered nurses with an advanced degree. We either have a master's degree and also a doctoral degree if you so choose. Whereas licensed midwives can come from any profession. They can have a 4-year degree, a 2-year degree. It just depends, but they are not registered nurses. They don't function in that capacity. So the way that we work is slightly different, but we are all midwives. We are all trained to attend birth. Some of us may focus more on gynecological care, perimenopause care, teaching, right? I teach as well. So I hope that answers your question a little bit, or just gives you an idea of the behemoth of that this really is, right? It's so mired in a lot of layered things.
When we talk about maternity care deserts as well, when we passed our bill and the California Medical Association was like, this isn't needed, blah, blah, blah. There were 7 counties at that time that had no obstetrical care at all. And I think now that problem is growing. There's going to be a shortage of obstetricians. And in addition to that, so many hospitals are closing their maternity units. And one of the models that we're trying to work on is creating midwifery practices and birth centers that can then go refer to hospitals for emergency care. So like general surgeons, if there's no OB or OB unit at the hospital, general surgeons can practice C-sections, and we're creating protocols, not just we, but a collective group of people for hospitals to deal with emergencies, because they are going to happen. It's just the way it is. So we're in a pretty bad place when it comes to maternal and reproductive health, and we're probably in one of the best states of any other state. So
yeah. And another way that we helps the support of training of midwives is also when you do have a birth center or you do have a clinic, say like just a regular family clinic or whatnot, anywhere that you hire midwives, then we also encourage that you train midwives. So that's another way that you can really support the training of midwives, because when you're in school, you need a place to do like your residency, right? Your actual clinical training. So we are working really hard to identify partners across the state, up and down the state of California, that would support taking midwifery students once they're in school so that they can finish their training, train there, learn, and then be ready to serve their community once they're done.
Super, super helpful. I'm going to ask a question. I really do not have the answer to this, but I had a friend who was OBGYN and practiced for many years, delivered many babies, really enjoyed it. And then her malpractice got so high that it was actually more than she was earning. Do you think those sort of insurance issues are part of what's driving people away, as part of the structural problems?
Olivia, do you want to start with that one?
Yeah. Yes and no. In the state of California, midwives don't have to practice with insurance when they're not in the hospital. However, you put yourself more at risk when you don't have it. So the majority of licensed midwives that I know that do out of hospital birth, they do not carry insurance. Also, interestingly enough, though, because of the model of care and the trust between the provider and their clients, they don't get sued very much either, and they have better outcomes, right? For the nurse midwife, if you work in any institution, you do have malpractice insurance. And a lot of the time, when institutions are considering closing the midwifery panel or the midwifery service, one of the big sticking points is the malpractice insurance. Is we have to pay so much more because of the risk of OB, the risk of you being in the hospital, things of going wrong, that a lot of the time, even the clinics will keep midwives, but only doing OBGYN care, but not doing birth, right? Less malpractice insurance. So it always, always, always is a major factor in my experience and from what I've seen.
So liability insurance is very, very expensive, and that's one of the reasons we don't have that many obstetricians, because it is so prohibitive. And midwives who want to own birth centers, there's been a crisis of birth center closures in California. I can't remember how many have closed, but we're way down from where we were. And the reason why is because they cannot meet their bottom line in terms of what they get reimbursed by insurance. You know, it's just it's not sustainable at all. And part of that is if you have a birth center and you want to be licensed in the state and be covered and receive insurance, you have to have liability insurance. So it's a huge factor and a big problem. I would love to know how many people even know what midwives do and what kind of our scope of practice and our role is. I don't know. There's such a difference in all the audiences we talk about. Some people confuse us with doulas and don't really know how we differ. Are there any questions coming up about that? Or I don't want to speak down to the crowd if everybody is really informed about that.
Well, I know, because it's the League of Women Voters and it's really about like policy having impact on health outcomes. And I think that there's a lot of conjecture about why our birth outcomes are so poor, both for babies and for birthing parents. I was wondering if you have some ideas of like, what do you think like makes us so different from the rest of the developed world? And are there policies that could inform and change it, or are there just huge barriers about, I mean, I know a lot about people would like have everyone have decent insurance. That's a huge barrier.
I can try to start with this one. In terms of like maternity care, we have a very medicalized model of care. And so when a woman, goes into a hospital, and a lot of times we'll use one intervention, which turns into another and another and another and another. And then we go down this path, and our C-section rate is, depending on the hospital you walk into, I haven't looked at more recent statistics, but I did a lot of talks on this. The C-section rate in any given hospital can be anywhere from about 13% to up to about 70%. And the biggest reason there is not how high risk the patients are, but the culture of the hospital that you walk into. And the more C-sections a woman has, the more risky that her pregnancy and her births are. And so we just accept our medicalized model of care here, for pregnancy and birth, but there are real consequences to it. And I'm not saying that medical intervention is bad. It's so important and so necessary when we have to do C-sections and we have emergencies. But if we treat everybody the same way, we really raise, different outcomes that did not actually need to happen. C-sections, higher rates of postpartum hemorrhage and infection and everything else. That's one factor. But I also feel like within our healthcare system, if you are a Medi-Cal patient, a lot of providers won't take Medi-Cal because they don't reimburse enough. And then there's an access issue. People of lower resource communities can't get the care that they need. And then there's also just really blatant racism in healthcare. And that may be really hard for people to hear, but I don't know if anybody's heard about Serena Williams' story, but she gave birth and she was actually, I think she had had a pulmonary embolism in the past. She was telling them she had one. They weren't listening to her. So if they're not listening to her, you can imagine how other women are treated that are not famous celebrities.
Yeah, I mean, piggybacking off of what Kathleen said, it's the League of Women Voters. So the way to really get involved in policy is to kind of familiarize yourself with the organizations that really support this work. Sharon just put on there the CMQCC, also MACA or MACA. These are all organizations that really support policy, push policy. They are collaboratives. And once you get involved and understand, then you can support the policies that come out of that. We recently this year just passed, I think, three big bills, Kathleen, if you remember which ones they are, supporting midwifery care. And so coming back a little bit, how Kathleen said, our high maternal mortality rates, it is basically because we medicalize birth so much for everybody. And like she said, also because of epigenetics, right? So basically the study that we realized that it doesn't matter your socioeconomic background, It doesn't matter of drug use. It doesn't matter of where you come from. The stressors that people face continuously has a negative effect on them, right? So it's not about race, it's about racism, right?
Yep.
There's not actually anything wrong with our bodies or Indigenous women's bodies or anybody else's bodies who's constantly just kind of fighting for survival. It's what that does to us over time. So we have that element that is really, really big, right? And addressing that and understanding that. The other element is how we respond to that. And so that's why midwifery, doula care, this type of care that has been around forever, the reason other countries tend to be more successful is because we are the first line. We're the status quo. So in other words, when you go to the dentist, you don't go to like the orthodontic surgeon first to get a cleaning, right? Like you go and get your cleaning, and then if you've got cavities, then you go to the next step. Well, here we go like straight to the surgeon. So it's not, it's not hard to understand how then we end up with so many surgeries and so many things when you could understand what midwifery is and the way that we naturally do things, and then we appropriately respond when we need to. But because we go from like 0 to 100, this is why we have this issue without acknowledging the systemic issues that we do have. So for those of you who really want to get proactive, that's how I would recommend that you do it. Get it, familiarize yourself. And like I say, it's such an easy internet search, and she's given you some really great links here in the chat. Go look at these organizations, understand how you can support, because we're always running up against systemic things that we have to figure out. As we said, a couple of years ago, we finally got rid of the language that said we had to have physician supervision, meaning it was just language. We had to have a doctor over us all the time, and it wasn't necessary. It was just hindering, right? Hindering access to care. So we finally got that removed. Great. So now how can you support in the next step? We've realized, great, we got that removed, but now how do we implement that in the system? If you have a system that is so ingrained, just because the laws changed, well, did the hospitals change their rules, right? Do people even know? So now what is the next step? So to improve this, we need people to get more educated as to what the options are as far as maternity care in this country, what that even looks like, and how you can best support with your vote and with your power. And that is exactly how. There's so many organizations and there's so many ways. So reach out to midwives, look at these organizations, and start informing yourself so that you can support these policies and calling to your state or local legislature to make the change.
One of the things about physician supervision too that people may not understand is they were never present at birth. They were never present at prenatal visits. They were never present at all. It was a signature on a piece of paper. That's what we needed, and it was exceedingly difficult to get. So it's not like it improved outcomes in any way, shape, or form, but it allowed physicians to give us permission to practice or not give us permission to practice. And now we don't have that anymore. So we can have independent practice. But again, there's still so many legislative and not legislative, regulatory and institutional changes that have to have changed to make this better. And the foundation is funding experts to advocate with the Department of Healthcare Services and all the other regulatory agencies, and even in hospitals, and with practices that want to bring on midwives, but they don't know how to do it, and midwives who want to open practices, but they want to do it legally, et cetera.
So this is a great segue into my next question, which is, a few years ago, I was in DC, and I actually was at one of the Smithsonian museums, and they had a video that was for training granny midwives in the South. And I was blown away at how incredibly detailed oriented and this was. And then, granny midwives were made illegal because they were not considered safe, though the stats actually showed that they were often safer than hospitals. And so I think one thing that's happening today that sort of mirrors that ugly racist history is that there's a lot of dis, and malinformation at the same time as low digital literacy and low healthcare literacy. So I think that there is this way that people don't even understand what the birth options are. And they are really willing to just say, well, this is my good hospital in my neighborhood. I totally trust whatever they do. And I'm wondering, is there a way, you were saying like some of the hospitals just have a C-section culture, that we undo some of the culture of the physicians, of the hospitals, and the patients themselves to kind of embrace what would ultimately be much healthier births for our babies.
I will say that there's been a lot of research done, and even if hospitals employ a midwife or midwives, their outcomes are better. It changes the culture, and it's not an easy job because these institutional structures are really hard to change. And just continued advocacy and pushing. I worked for Kaiser. I just resigned a few years ago, and the midwives there are really pushing to be able to be involved in the decisions that are made. And we were making slow progress, but I mean, it's a behemoth to change, and there's no impetus to change, and it's working for the people who it's working for, and they don't want change. And I'm saying all the difficult parts about it and how do we make the change. We're trying really hard, and it's very difficult. I think the most important thing is for women for us to educate women, and for women to demand a different type of an experience, and midwives in their where they're delivering and where they are, because if it comes down to money and cents, and there's another hospital next door who has midwives and all the patients want to go there, that's going to make the difference. So
I think also, I think a lot of the times it comes down to trust, right? So one of the things I hear often is like, oh my gosh, you deliver babies at home or out of hospital. How is it safe? What happens if there's an emergency, right? So there's this idea that the hospital is safer. Except for the fact that if you think about any time you go to the hospital, you only go to the hospital when there are emergencies, right? Any other time in your life, nobody's going to the hospital for their standard of care, right? You're only going when things are falling apart. Birth, most of the time, things are not falling apart. Things are going exactly the way they're supposed to go, right? So, how do you change the system, honey? I mean, I feel like if we had that question, we would be gazillionaires and the system would be changed. I mean, you're talking about the patriarchy, you're talking about all of these things. It's so ingrained in all of that. Our medical system, the hospital system, the way that they're wanting to make money from everything. Um, all of those ways are the ways that we make change. But I actually think, like Kathleen said, educating women. And also, I have always hoped, I don't know if you guys remember this, but I don't know, when I was growing up in school, you always had like career day, or people's parents came and told you. I never heard about a midwife ever in my life, right? And if you hear about midwives, it's something like they're witches dancing naked under the moon, which I'm not opposed to, by the way. But I'm just saying, it's always like this thing. It's always dressed in a different viewpoint. It's always less than. But if we get people from the time they're young, one of the things that I'm passionate about is starting early childhood education. If you understand this as the norm from the beginning, it's not out there for you. Like you're not out of the norm when you think about it when you get older. People who come from other countries are like, where's the midwife? And they're like, what do you mean midwives? For them, it's so strange that there's no midwife. What does that mean? So we have to normalize it somehow. And I think an easier way, we have to work within the system to dismantle the system. But another way, I think, is early education so that we all grow up understanding, and this is normal to us. When you can understand, do you know that midwives still exist? Do you know what midwives are? And that there's trust in that ability. You have to remember, with the history of midwifery in this country, when they criminalized midwifery, it was very easy. Women were a perfect target. The original midwifery is the oldest profession in the world. The oldest profession, right? That and sex work, essentially. Women's profession is the oldest in the world. And when doctors took it over, it was very easy to criminalize women. There was indigenous women, enslaved women, and immigrant women who did this. And you served your community. And we know that when people of the community serve their own community, outcomes are better because they're your people, right? You understand how to support these people in the way that they need. So when that was criminalized, another thing was the patriarchy. Because of patriarchal norms, a lot of the time there was this idea that men knew better. You trusted men. There are accounts of women who trusted men gynecologists and would go to the man versus the first female gynecologist, right? They'd rather go to them because somehow you trusted that the men knew better. So you're not just talking about access, you're also talking about changing belief systems. How do you get, as a whole, people over to trust that these midwives actually are trained appropriately, can take care of you, can acknowledge when there is an emergency and we need a higher level of care. So I really think it's very nuanced in a lot of things, but systematically and within the system, midwives have been fighting forever, right? That's what our legislation is about, is getting rights and getting access. But I think if we bring in the education and also understand kind of what we're working with as far as belief systems, we could also come at it from a different angle.
And I think I read somewhere, and I might not have the stats exactly right, that in the Netherlands, 90% of births are delivered by midwives, and they have some of the best birth outcomes in the world. So if we have data, and then we're in this time when people don't even like data, and our government's pulling data, you know, could you just imagine if every doctor who performed a C-section had to present in front of the morbidity and mortality report to justify why they went to that extreme? And then there were triggered initiatives of like trainings to prevent C-sections. I mean, I think there are structural things we could build into the system, but again, you have patriarchy, you have capitalism, and you have a system that's designed to work exactly the way it's supposed to work, but you know, it's having terrible outcomes. And I think it's an important fight to have.
Yeah.
And I will say that doctors who train with midwives or work with midwives tend to do better as well. I want to make sure that we don't just demonize physicians because they work really hard and a lot of them have a great heart and want to come in. It's the way they're trained. It's the model in which they are trained. So those who are trained with midwives, if we changed it, they would understand also better how to approach it in a non-disease oriented way. So I want to say, you know, there are a lot of great physicians out there, but a lot of the time we are all victims of the system in which we are raised.
Yep. Yes, I can't agree more. Like even female physicians, they are raised in this patriarchal environment where they have to function in a certain way to be a part of the system. And so do we as midwives. Sometimes when we know what's best, but we want to advocate for patients in the way we know best, but we know we can't in the environments we're in the hospital setting. And that's really, really a difficult thing that we deal with on an ongoing basis. But can't remember what I was going to say. Something else about, I don't know, it'll come to me.
Well, you did mention something earlier where you said like when you're in the hospital, you sort of start this intervention that leads to other interventions. And I know that, you know, they like to have you NPO when you're no food or drink when you're delivering in a hospital in case you need anesthesia, in case you vomit, in case you aspirate vomit. But when you deny muscles food and drink, they stop working. And then they go, oh, look, we made you NPO. Now your labor is not progressing. So we have to give you Pitocin. Oh, and now it hurts more. So we'll give you pain medicine, which also slows labor. So that sort of, you know, I think of it as like a domino effect. And then they like, the message is the woman, like, you didn't push hard enough. You didn't do a good enough job. You weren't brave enough. And I think that sort of, the system creates the problem and then blames the victim is really ugly.
It is. And as you said, in many other countries, they have better outcomes. Midwives, they have a lot more midwives that are delivering babies in their systems. So it's a different system completely.
So if you had a magic wand and could change one thing, you could only change one thing, what would the one thing be?
Olivia?
As far as like midwives and doctors, like the system.
Yeah.
The system.
Yeah, I think socialized healthcare. I think if it stopped being about money, uh, it would just be obvious that these provide better health outcomes. So that's what we would do, you know?
The one thing that I think if we could change is we have so much data to back up everything that we're saying, and it's just not out there. And in the medical community, this data is out there, but it's not even acknowledged. If we would look at the evidence and act in a manner that the evidence supports, I think that we would, you know, instead of just following the systems that we have in place.
And here's a great question. So someone asked from the audience, what specifically do midwives do differently than physicians in hospitals? how does the way they are trained change?
Change that. You froze up for a moment. How do we do things differently? Well, first of all, our whole approach is
Like the first part of it, sorry.
You want me to go ahead and try to answer it?
Sorry. I just think maybe it's in two parts. So what do midwives do differently than physicians in hospitals? And once we come up with that, how do we, how does the way they're trained, can that be the place where we start making the changes?
One small thing I want to say before I answer this, what Olivia said about physicians that are trained with midwives. I worked in Alta Bates. You probably all know Alta Bates. I worked there, and I told one of the physicians that I was a midwife and I came from UCSF. And so I knew the midwives who were there, and this physician in particular started crying because she had such a wonderful experience and was so moved in her training, the way she was trained by midwives. So it makes a huge difference when midwives are involved in training, and there are academic centers like UCSF and others that have midwives train the obstetricians. What specifically do we do that's different? I would say, gosh, physicians are, again, trained to deal with pathology. And it's not that they're all like that. And it's not that I'm saying physicians are the enemy, because thank God for them. And I'm so happy that we work in teams the way we do. But midwives listen, they take the time as much as they can in the system that we have. They acknowledge, they talk, again, they listen, and we tend not to intervene unless there's a medical reason to intervene. There's a big push to physiologic birth that many hospitals have tried to get their physicians to do. So just allowing a woman's body do what it does without intervening. And hospitals have called it physiologic birth, but really it's the midwifery model of care. I used to be so put off by that term because it's what we've always done and what we've always, believed in. That's our philosophy. That's our paradigm.
Yeah, so it's frameworks, right? So the medicine framework and the midwifery framework. We believe that the body knows what it's doing, right? Whereas usually the physician framework is there's something wrong and we've got to fix it, right? That's what kind of created all the forceps birth, scopolamine, all these things, because you got to make it better, right? So that's why there's a lot of intervention. That's why women lay down in the hospital. That's why you have anesthesia. You have all of these things. Whereas midwifery model of care is there's nothing wrong happening. Like this is what we were hoping to get to, right? Like so when I take care of women and they're like, I'm so scared it's getting close. I was like, but this is what this is what we've been working for. Right? This baby has to come out, right? So framing it as the normal thing, not the broken thing, right? So everything that we do comes from a place of supporting the woman. I always tell my patients and my clients, when I do out of hospital birth, I'm like, my hope for you is that your birth is so smooth that you kind of whisper to your husband, like, we did this all by ourselves. Why did we even need the midwife, right? Like she was just here. That's my hope, right? But you want me there because I'm skilled to jump in should I need it. And it's just a different perspective. So it changes everything that we do, right? Checking, women who are like, they checked my cervix, or they're going to pull the baby out, all of these things. I don't really do that, right? Unless I have to. There are a lot of women who are like, I'm 37 weeks. When are you going to start checking to see if I'm dilated? I whisper, that your baby can be born if I never check your cervix, right? Like ever, right? Or, so just education. Midwife literally means with woman. So we just walk the path with you. We're not there to fix it. We're not there because we can make it better. There's nothing wrong with your body. The medical model does look at it as a way to intervene. We're always trying to come up with better ways to make the experience better. The more we do that, the worse it gets. That's the problem. And also, it's a lot of fear-based teaching. A lot of physicians are very afraid. They're not very trained in vaginal birth. They're very trained in operative birth. They got this. Like if you want somebody to jump in who's going to do heroic things, right? We can too. We're just very reluctant to do it. It's like, unless I know for a fact you need to, you've got this. You've got this. We sit and we coach you. A lot of physicians are very afraid. They're very anxious. They're very like, oh my God, I have to do something. Something's going to go wrong. What if something goes wrong? What if something goes wrong? What if something goes wrong? So it's a different viewpoint. So you come with a different energy. And also, I do have to be honest and say, in this country, our litigious culture makes you more afraid. Right?
Mhm.
OB is like the most litigated specialty out of all of them, right? So there's also that. It's also like our fear of what if something goes wrong. So if you feel like you can control it more, you have less fear. With a C-section, I can control it. At least you think you can control it, right? You feel more in control. When you're doing all of these things, stretching a woman, doing all of these things, you feel more in control. But midwifery is about not being in control, is how I see it.
I once heard that physicians treat and nurses heal.
Yeah.
And I've
There
always
you
liked
go,
that
right
quote.
there. And a
Yeah.
couple of words that haven't been spoken, but that I think is the most important thing I did for my 30 years practicing at the bedside with midwifery is empowerment. I mean, we just really, really make women believe in their bodies, and we empower them, and we treat them with respect and dignity. And, no matter what happens in a birth, my goal was always to make the women feel empowered. And when Olivia speaks of the fear, there's so much fear in our culture about birth. And if you don't think that impacts your body and how you walk into your labor, that's such a misconception, because everything inside of us, how it affects the hormones and everything else, and how we're going to progress in that environment, and with all that fear and that adrenaline going in our bodies. And when Olivia said at 37 weeks, women want to know, when are you going to start checking my cervix? Well, you could be closed and long and go into labor that night. You could be 4 centimeters long and still be pregnant in 3 weeks. It doesn't give us information. We just are as a culture, a medical culture, having information we think is going to solve the problem, and intervening is going to solve the problem, and it doesn't. You can't make women's bodies perform better than they already know how to perform.
That's very well said. I often wonder, like, how did the medical world decide that the ideal amount of body weight to gain during pregnancy was 24 to 30 pounds? Because I've had friends who've lost weight and had 8-pound babies, and I've had friends gain 80 pounds and have 8-pound babies. And I'm like, what is this number that's like some magic number that makes so many women feel inadequate?
There's so much about all
Oh,
of it that makes women feel inadequate. Olivia did her dissertation, I believe, on this subject of, yeah, I'll let her speak to that.
yeah, there's just a whole other ism. It's like fatism and fat phobia and implicit biases around big bodies, right? And what that actually means. I did my whole doctoral research on it because it's just another way that we medicalize things. And what does it actually give? Remember, the medical establishment sees yourself as scientists, right? It's data gathering. Unfortunately, though, humans are messy. We're not that, right? So we keep trying to fit us into these little boxes, and we keep trying to say if 2 + 2 = 4, then you know what I mean? And a lot of the time, we cause harm with that. A lot of the time, it's weaponized in that way. And so, for people's bodies who don't fit the status quo or don't fit this box, or don't, and it's most people actually, then it causes a lot of harm, because what do? You cause anxiety, stress, fear, a lot of things. So yeah, the medicalization of the body and of birth and all of those things is quite sad if you look at all the things that it does, and the fact that we're hoping to make things better, but we don't really. It's a really interesting dichotomy.
Well, I think about, like, when you're talking about this, the like fear base that's instilled so that you're full of fear hormones, and then like this body inadequate hatred of body, and like jumping off into parenthood as a new parent, coming from like fear and self-hatred, it is such a different kind of parenting than feeling empowered and feeling like beautiful and strong, and then you jump into new parenthood, which is challenging. Your sleep cycle is different, your focus is different, your learning curve has to go way up. And I just think I didn't really understand till I've heard you speak how important this is as an issue for our society.
I
Like, I'm
mean,
aware of the facts, but it's really touching my heart.
if you think about it, Sharon, here's a really great example. Oxytocin, right? The hormone we have in our body. When people give Pitocin in the hospital to give you contractions, that's the synthetic form of what we have in our bodies that triggers labor and gives you contractions. Funnily enough, too much excitement, too much light, too many things will make your body stop pumping it out. Your labor will stall. If you want a woman to go back into labor, turn off the lights, you quiet things down, you make her feel at peace, and her body will get back to it. So when people think that it's like a little frou-frou in what we're talking about, that is actually even scientifically proven. We can see what happens when the body is under duress in that way, right? It's not going to function the way that it should. So there's so much, like Kathleen said, so much research. If you're somebody if you are somebody who is research focused and based, and you need stats and things to kind of come to your conclusion and your truth, then midwifery and this is so full of that, that it just supports what we're saying and even seeing it in the processes of the body.
And I always turned off the lights. So now I know why, but I was like, who decided that fluorescent lighting was
Yeah.
the best thing to heal under? I mean, nobody looks good or feels good with fluorescent lighting.
Or like stirrups, it's like a show. Everybody runs into the room. I was like, guys, this is like the poor female body. What if she has like, stage fright? It's like perform and everybody's there and everybody's staring. It's a very strange thing.
It's also the whole culture of, as soon as the woman walks into the hospital, she's put into a hospital gown, she's put in a bed, an IV is started before anything, before anything else is done. I mean, like she doesn't need an IV when she arrives. But like just being reclined and trying to labor that way, it doesn't work that way. If you're up and you're moving around and, especially in those early stages of labor, that's going to help your process along.
And gravity.
Active part of it.
Gravity.
I mean, gravity. It's like the simple
It's
thing.
so simple, but we are so far away from that. We don't even recognize that in our brains as a culture and a society. So,
I loved Olivia, you said this at the beginning, like we want like kids to know right away, like midwifery is a career option. Having a midwife when you decide to start your family is an option. And I remember talking to the chancellor of the school system saying like health literacy is so bad. Can't we start doing health literacy training from kindergarten or even preschool on? And indeed, my kids' preschool, they had a huge strep throat outbreak and nobody was washing their hands well. And we like got the kids to wash their hands better and the strep throat epidemic went away in the preschool. But I love this idea of like midwives coming to schools, talking about why they chose that, talking about the beautiful ways like babies are born into this world. And I have to say, like, I grew up with physician parents. I knew I'd be in the medical field in some way or the other. And I happened to go to nursing school at Vanderbilt. And one of my classmates was a lay midwife from the farm. And she introduced me to Ina May Gaskin. And then one of our classmates actually gave birth on the farm. I had never known there was something called home births. I didn't know there were like lay midwives. This was just such a novel. And when my friend told me about her birth experience there, I was like, oh, that's what I want to do. And without that exposure, it wouldn't have even been in my imagination. So we have to bring it to everyone's imagination.
if anyone on this webinar can see a video of a home birth, there are some movies about home birth and what it looks like and what it is. I'm drawing a blank right now, but it is an amazing. It's such a culture shift and it's such a beautiful thing. And that's what birth should be. It should be not at the convenience of the healthcare system, like in terms of when we're going to schedule, when we're going to do your C-section or whatever. But it should be completely evolving around the woman and the baby and her family. So, and that's what home birth is. And
Yeah, and sorry.
I'm sorry, the amount of care you will get, like in our traditional system, you get one postpartum 6-week visit. And this is when a lot of the bad outcomes happen. Postpartum, that's what our system offers women. If you have a home birth or you have a birth center birth, you get first day, second day, 1 week, 2 weeks, I mean, it's just insane the amount of attention you are given, and that stops bad outcomes because we see them when they're happening.
And the other thing, as a League of Women Voters, if you want to support something that supports the safety of out-of-hospital birth, what research has shown consistently, um, if there are bad outcomes in the out-of-hospital birth community, it is because we don't have seamless transfer, right? So in other countries where midwifery is really well integrated, people have birth outside of the hospital. But anytime things are identified that's like you need a higher level of care, it's time for you to go to the hospital, the transfer is seamless, right? That to get there, the respect between professionals in this country, because it is not a part of our system, the transfer is not seamless. A lot of the time, the providers are a little bit worried, or the clients are worried. It's like, I don't, which hospital do we go to? Will they talk down to the midwife? Will they demonize you for wanting to have an out-of-hospital birth? So there's a lot of distrust in the system. So if ever you're looking for policies or things to vote on to support safe transfer, supporting groups that are working on safe transfer choices, there are a lot of models and toolkits out there. That is another way to really support out-of-hospital and community birth and making more safety for everybody. It's this, how do we transfer when we can identify early on that it's time to go without me as a midwife, for example, having to worry that they're going to mistreat me at the hospital, that they're going to mistreat my client, right? How does this work? Where are our sanctuary hospitals? And we have worked at CNMF. We have worked with community midwives who have created this and have identified some hospitals who will work with midwives and who will identify hospitals that the midwife can call the labor and delivery unit and say, I've got a patient, I want to transfer her. And there's respect and there's easy, seamless transfer. And that is so amazing. And that's one of the big components that's missing from this being a cohesive system.
I also think the insurance payments, because when I opted to have a home birth for my first child, which was a while ago, I remember I was carrying Blue Cross Blue Shield and they were like, we don't cover home births. And I said, I want you to know that the prenatal care, the birth, and the postnatal care will cost less than the room rate at the hospital. Like it only makes sense to say we want to cover this.
Right.
So I wonder if there's some legislative options there.
We are working on all that stuff. And the issue, midwives really want to take care of, people on Medi-Cal and people who don't have as many resources, but the only women that can afford that kind of care are often, women who have means. And so raising Medi-Cal reimbursement rates and making it so that insurers have to pay for midwives. Right now, there is a law in place that says any Medi-Cal plan has to have one midwife on their panel, but I mean, that's really inadequate, right? Depending on where you are. So there's a lot of legislative change that we have done, and there's a lot every single year since 2019 when we passed SB 1237. I think except for 2020, because we were so exhausted, we've passed more midwifery legislation. And the legislature is really, they're very supportive, and so is Governor Newsom. I'm
He
so
has been.
grateful.
It's been amazing. Yeah.
He's signed all of our bills, even
That's great.
against a lot of opposition from California Medical Association.
And
Yeah.
I actually think that maybe this was all supposed to happen. There's some kismet, because I think as you're working on bills, League of Women Voters is nonpartisan, but we do support bills, not candidates. Like if we can like hear about what you're working on and lend our voice and our support to your work, I would so love to do that, because I'm there as a nurse practitioner who always worked with communities who are under-resourced. Really, health equity is I think the most important thing I can work on. And this is probably one of the most important spaces to make that happen.
And when you start at pregnancy and birth, you are starting at the very, very beginning, and you treat people with dignity. And that's a great place for them to launch from, Yeah, the foundation, California Nurse Midwives Foundation, we just changed our name officially with the state, but not on all of our materials right now. We are now the Midwifery Collective, because we started out of the association, our professional association, but we want to bring everybody together, licensed midwife, nurse midwives, people who are consumers of midwifery, everyone together to work on these issues. And we don't want to do it in silos. We want to do it together. And some of the Olivia gave an example of one of the projects that we've done, one in Northern California, one in Southern California, trying to make transfers respectful between hospitals and out-of-hospital providers. And another one of the big projects we're funding right now is a couple of women who have mobile clinics. So they are outfitting vans as like a prenatal clinic and going out into immigrant communities so that they can get the care they need instead of going into the hospital system right now when with all the deportations and everything that's happening. So it's really, really wonderful to be able to do this kind of work and to have the funding to be able to do it. So we feel really blessed.
Well, I'm going to write a check, and I really hope everyone who's either watching this live or recording, because I think, like you were saying, it's right at the beginning. So if we could give people resources that gave them the power to have beautiful births, you know, that would be really transformative. And so here is some other question that just came in. As a hospital nursing administrator, what can we do to support demedicalizing birth? I'm finding it very challenging to staff my hospitals in ways that align with midwifery models, both for CNMs and RNs. So great question from a hospital administrator.
I think some things, well, maybe not so simple, but something that usually doesn't get tons of feedback because it's happened on every labor and delivery unit I've worked on is training of the nurses. So like really getting the nurses to understand. Most nurses only know the medical model. They've only seen that. And as we know, change happens with nursing. So educating the nurses, maybe having some of the midwives educate the nurses, and maybe starting with intermittent auscultation, which the way that we monitor babies. There are a lot of policies out there, and it's something that's usually easy, and hospital administration doesn't usually push back because it's just like on labor and delivery. But when I've seen change happen, and Kathleen can give you her experience, it's been mostly through nursing education and the nurses kind of pushing back. But unfortunately, most nurses don't know what they don't know. So I would say bringing the nurse midwives or midwifery education into nursing education, and I think you start to see big changes. I mean, even once we had a doctor who wanted to do vaginal breech, because that's a whole nother thing. And at one hospital, they were very successful because they trained the nurses and they brought nursing along with them. And at the other one, they did not, and nursing pushed back so hard it lasted a week and it never was able to come back. So I'm a big proponent of going with nursing education, and they're the ones who are at the bedside and really understand. So they understand that there's a different way to do things.
Couldn't agree more. As a nursing administrator, when you think about it, the doctors come when the nurses call them. And if the nurses can get patients to, so they don't have dysfunctional labor, and super drawn out, dilation, so the doctors aren't coming, and there are so many interventions that you can do to make that happen. When I was at Kaiser, I led like a whole physiologic birth thing for a couple years, and we did all these we did these trainings for the nurses, we did trainings for the physicians, we did trainings for the anesthesiologists. It was all run by a couple of nurses and me, and we brought our C-section rate way down. I don't know that it's still there. It's really ongoing work that you have to do because new people come in and they're trained the way they're trained. It's ongoing trainings that you have to do, but I'm happy to talk to you about that. There are consultants you can bring in to do that kind of training for your nurses, and that will really make a difference. It's hard to change cultures. It really is hard, but it's possible.
Yeah, I was at the hospital where I am now. The nurses pretty much almost function like midwives, except for catching the babies. They do everything in the midwifery model of care. They barely check cervixes. They move patients a lot. They encourage women. They keep them connected to the monitor, which still is a thing. You win some, you lose some. They push with the patients, but they don't push with the patients on their backs. You know what I mean? Like they basically have really, really integrated. So basically the physicians come in and catch, and me as a midwife who's there, I still teach them a little bit. For example, we don't turn on the lights. I tell everybody, please stop turning on all these lights. They like to break down the bed. So that a lot of the time the bottom portion of the bed. They like to put women in stirrups. They really stress out when I'm like, it's fine, just let her do what she wants. It's a very stressful thing for the nurses, right? They're like, what position do you want her in? Whatever she wants. She could be standing over my head. I don't care. It's very stressful for them. So, but such better patient satisfaction, lower infection rates, lower C-section rates. Everything just gets better when nursing is educated in a different model. I think it's nursing. Physicians too, our physician counterparts, but
Yeah.
I'm a nurse.
And the follow-up question is that the hospital administrator is finding the C-suite administration is more of a barrier than the nurses.
C-suite administration.
Like the CEO and the CMO and all of them. Yeah.
Oh.
Yeah. They have a lot of strong opinions.
Isn't that interesting though? Because like this care is cheaper. There are better outcomes. And this is how it is. Insurers, they'd save so much more money if they would embrace this. Hospitals would have better outcomes. Hospitals would save money, but it's this whole culture that is trickle down and patriarchal. And I mean, literally the way midwives were treated and how they were, you know, ostracized, it's still a thing.
Oh, yeah.
It's
And I
just,
think, and a lot of the time, Kathleen, in my experience, it comes from the CMO, right? It's like they're a physician and it's this thing. So all the C-suite stays this way. Maybe it should be like there needs to be a chief nurse, a chief midwifery or a chief nursing
heck yeah, get
officer who
midwives
has,
in those.
yeah, a CNO that's also a midwife, that has the same, but
Um,
it's hard in the hospitals I've worked at. That it's usually if it's the C-suite, it comes from the CMO, the chief medical officer.
Officer.
And the dirty secret is that they actually make more money when it's medicalized. They make
That's
more
true.
money for the insurance
That's
company.
true.
So saving money isn't exactly the
You're right.
idea we want it to be. And
You're right. You're
when
absolutely
someone
right.
says there's a misconception that by assigning more nursing hours per birth, it's driving up costs. So another part of the way the administration looks at the finances around it that really is not great for the patients.
Yeah. Another thing, well, one thing that I also see is like normal is becoming narrower and narrower and narrower. More people have to get induced for like various reasons, like it's changed so much over time and it makes it harder to do this. But the one thing about like the nurses, if you train the nurses and they will embrace it, once they start seeing the changes and they recognize like, wow, this shit works. They're so excited to like be able to be so powerful in a woman's experience. They really are. Instead of just looking at a monitor the entire time and, changing the pads on the bed or whatever. Those, just those tasks where it's and charting and
And again, I think it also comes to safety, right? People always think this is what's safe. This is what's keeping a woman safe. When you learn that actually it's the opposite, that's like mind-boggling for a lot of nurses, right? This is dangerous. This is dangerous. This is dangerous. Actually, no, what we're doing right now is more dangerous and causes more harm.
So I was wondering if you guys were coming almost to the end. We were worried like without a presentation, but I think this was the most amazing time. And people are texting me going, you guys are fucking amazing. I'm getting texts. So this is great. I was wondering if you could just talk a little bit about doulas and then, any final closing thoughts you have.
I'll start. So a doula offers support, physical and emotional support to a woman during the process. She also is often involved like in the prenatal process and then postnatally as well. And in our medicalized system where most women don't have a midwife, I think it's imperative that people have doulas. Midwives are we do the same things, but we're also healthcare providers. So there's a big distinction there in that, we, in a hospital setting, we can order epidurals, we can order antibiotics, we do all those other things as well as offering the support and everything. In California, doulas now, Medi-Cal will reimburse doulas for the care that they're giving. It's not a perfect system. It probably is hard to go through the paperwork of getting reimbursed, but they've really increased the reimbursement for doulas, and we're working to do that as well for midwives. What about you, Olivia?
Yeah, I mean, the power from the doula comes from the midwifery model of care, right? It's the evidence and the idea that a woman having support during her labor is as effective, if not more, than epidural pain relief, right? Women need constant support. You need a coach. You need somebody who's not afraid, somebody who can walk you through it. That improves their outcomes. So doulas traditionally worked with midwives in the out-of-hospital community because you know that it works really well. And like Kathleen said, when you don't have that support in the hospital, when you don't have it either from nursing because of staffing, you don't have it from midwives, doulas can come in and do an amazing job. You have doulas for the postpartum, you have doulas, death doulas. Doula now has become like an umbrella term for somebody who has a certification and they can support you with other modalities. A lawyer can be a doula, anybody can be a doula. I think it's a weekend certification, right? But their positive influence on somebody's experience is amazing. So that's the difference between like what a doula does and what a midwife does together. When you have an amazing doula and a good team as a team, it's amazing. The challenge comes sometimes when people get confused about what a doula and what a midwife is. And a lot of the time, since the doula is the one who creates the relationship, when you're in the hospital, you don't have that relationship. It becomes a little contentious, I think, when the clients and the patients want to ask their doula all of their medical questions, right, to get the advice. And that's where if you've ever seen some what's the word? I just went blank. But if you've seen some contention, it comes from that. But I love a good doula. I think they make an amazing experience, amazing impact. And I love when I have a good doula with a patient because then I can trust when I walk out of that room. And even when I do home birth, same thing. When there's a doula there, they're my eyes and ears. It's amazing. It really makes a big difference. But there was a second part to that question, wasn't it, Sharon? It was about doulas and it was something else.
Oh, well, here comes another question that just came in. Will you be proposing CMS professional fee structure? I'm told that we can bill only 80% of the professional fees. This has locked us into a hospital by laws that requires an MD co-signature.
Most of that is probably inaccurate. And if you reach out to me, I'm not the expert in that anymore. My time is really spent now in fundraising and things like that, but we will hook you up with the expert on that question. Do you want me to put my email in the chat?
That would be great. And then, yes, my second part of the question is like, kind of your final thoughts, because we covered a lot of material, or anything you didn't get to say, or anything you want to leave us with.
Definitely donate to us. It's our end of the year fund giving raising. I'm going to put a shameless plug in, guys. We have so much work we need to do. So donate to us, donate to any other midwifery organizations. Get out there. If you are trying to figure out, especially this day and age when there's a lot of, hopelessness and sadness in the holidays, a cure for that is getting out there and getting in your community and getting into advocacy work. And if you're trying to find a new passion, women's health and midwifery is that, because we touch all the things. So come in, support, learn, look us up at CaliforniaNurseMidwivesFoundation.org. We're all there. You can always reach out to me. Thank you so much for having us. We love, love, love talking about what we do. We love giving the history about it. We really are here to, just move the human race forward, empower women. When you empower women and you empower children, you save communities. I mean, we are literally where life starts. So if you take care of us and you take care of the way we give birth in our bodies, we literally save the world. I know that's corny, but that is the truth. So thank you so much. It has been a pleasure and an honor to be here tonight.
I will just say, I hope you can hear our passion about what we do. I feel like I've been so blessed to have found midwifery and been a midwife all these years. The other thing that I will say is, if you are not pregnant and having a baby and don't plan on it, midwives actually can take care of women or individuals from adolescence to menopause. And so, we can do normal. Normal is defined in the legislation as low risk. And so that's kind of a nebulous term, but we can do all kinds of things with that. I just started.
I was going to say, put a shameless plug for you. Kathleen is focusing on midlife stuff. I also do I do a lot of gynecological care, but Kathleen, talk about your new baby.
I just started a business called Gentle Touch Wellness. I'll put my I'll
Yeah, if you could put
in
both
the chat, but it's
your business
basically
in and talk about it a little bit.
it's basically a virtual platform to help women with medical needs, mental health needs. I've done a lot of mental health training and perinatal extra support, education, guidance. So if you have a UTI and you don't want to go to your doctor and you just want somebody to help you talk through it, maybe order labs and give you medication. If you have a child who, a young gal who in your family or whatever that wants to be screened for sexually transmitted infections and treated, I can do that. I can help with mental health issues. I can prescribe SSRIs. There's all kinds of things, postpartum support. You know, if you're not getting the time and the questions answered that you want at your prenatal visits, I can help with that. And I really tried to make my fees affordable, and I'm trying to get on board to Medi-Cal so I can take care of that entire population as well. So
Yes, and people
my
are
new
asking for the
baby.
link to donate. So if you could put that in, that would be great too.
It is up here, California Nurse Midwives Foundation.org. If you go there, there's a donate page right there. It's really a beautiful website as well.
Excellent. I don't know if you want to put it in the front so people can click right. Oh, there it is. Thank you, Cynthia, for putting that in. This was absolutely amazing. I think you guys are just my new favorite heroes in nursing leadership. I'm thrilled we had this time together. I can't thank you enough for not only coming at the very last minute, but doing such an amazing job. I feel like I've learned and grown and been energized. So that is really incredible. Thank you so, so much. And again, shameless plug for League of Women Voters. We would love for you to get involved with us or your local chapter if you're not from around the Berkeley area. It's one of the best things I've done with my nursing career. I've only been on the board about a year now, and really policy is healthcare. And we're trying to really bring that up around every issue. That any policy that's happening has health ramifications. You want to talk about gun control, global warming, reproductive, it's all health. So we really need to have, people supporting both the nursing profession and places like League of Women Voter. And there's Kathleen's agency, Gentle Touch Wellness. I'll be spreading the word. Who knows, maybe I'll call you too, though I'm 10 years into menopause, don't really need the treatments anymore. But
sure you do. Sure you do.
Yes, you do. We can talk about that.
Okay. I would love to work with you. I just, I feel the energy.
There are certain things that all
Sharon, and anything you would go to an OBGYN for, you can go to a midwife for.
Yeah.
Pap smears, anything.
Yeah, I tend to see a women's health nurse practitioner, but I'm just really loving the energy here. So, that's great. And I want to wish everyone thank you for coming and have a wonderful holiday season, no matter what you celebrate. I feel like I'm entering it with joy now, which was not the way I felt in the beginning of today. And I want to thank you guys again, and hopefully we have some ways to support. And here it says, excellent presentation. And yesterday was World Advocacy Day, so this was super timely. Thank you, Adrienne, for being here. I know we're together on DNPs of Color, so nice to see you here.
I'm in DNPs of Color too.
Where were you in Oakland?
I was there.
Oh, I was the MC for half of it. Did you see me? Well, now we have to connect. Yeah. And I just really love this energy. So thank you everyone for coming. Thank you for our panelists for talking today. And I think we're going to move the arrow.
Thank you.
It was an honor. Thank you so much.